Hello, welcome to the Facelift course 2021. Unfortunately, I'm unable to be with you this year owing to travel restrictions. I do hope that this information is useful for you, and if you have any further questions or queries, please do not hesitate to contact me. My name is Dr. Julian De Silva, and I'm an oculo-facial plastic surgeon based in London, and I've completed fellowships both in Los Angeles and New York, and much of my facelift experience has originally come from colleagues in the US. I have no financial disclosures, and I request no photographs of any patients who used anywhere else. I like to acknowledge some of my previous colleagues who ran this course, which has been running over 15 years. Myself, I've been giving this course for over 5 years. And really the purpose of this course is really an introduction to facelift surgery. And in the past, we've had like a number of expert presenters who've presented over a number of different aspects of facelift surgery, but we've also had a cadaver dissection, and unfortunately we are not running that this year. The key aspects that we will cover in this course will include facial aging and relevant anatomy, the concepts of facelift surgery, how to plan both clinically and surgically, what anaesthesia can be used, the techniques that can be used in order to tighten and lift the SMAS, and also the key steps of facelift surgery when first starting, and of course knowledge of complications and how to avoid them. Now in a way the course today is really in the format of a lecture, but really to build up on your facelift experience to enable you to go out and conduct this kind of surgery also requires attending training courses, preceptor work, fellowship training, and if you're able to also visit and have cadaver experience, I think this will also be a considerable experience for you. And really, if we take like a leaf out of Malcolm Gladwell's book, Outliers, well, you really need to have 10,000 hours of experience of any specific task to be really skilled in that. And really that comes from a whole host of different areas when learning surgery. So firstly, we're going to look at facial aging and the relevant anatomy. So when we see a face, we often can tell which areas have corresponded to areas of aging. And there are really like three main areas. There's one area which can be described as changes of gravity, such as the jowls, where the cheeks have dropped down in order to like obscure the jawline, and often gives fullness along the jawline, change in the shape of the face from a more V shape to a more U shape. In addition to that, there's loss of volume, and this can be through like deepening of the nasolabial folds, shadows amongst the different areas of the face, and adding volume and lifting and restoring that volume to the higher up in the face can really rejuvenate the face. And then the third aspect is skin laxity, and as you get older, the skin loses that elastic property, which results in loose skin, and part of the facelift surgery is required to improve that. Now we're more frequently familiar with the changes around the eyes, the drooping, the loss of volume, the loose skin. In a way, we can use those same principles elsewhere in the lower third of the face. So aging really comes down to three specific areas: descent due to gravity, deflation due to loss of volume, and loss of elasticity and skin laxity. And how does this correspond? Well, we see jowls along the jawline with increased fullness. We see deepening of the nasolabial folds and marionettes. And we see in the neck platysmal bands and more volume and loose skin in this area. Deflation, well, this can be in the form of loss of fat and fat atrophy. It can be changes in the bone and bone resorption, and evolution in the skin with thinning. Of course, there are other parameters that are also important to consider with looking at a person's face. This includes the hairline, a receding hairline, the shape and appearance of the earlobe, the fullness and lower appearance of the submandibular glands, low hyoid, and of course the skin laxity. So let's have a look at the relevant facial anatomy and how this corresponds to this area. Well, really, when we're looking at the facial anatomy, there are really 5 key areas, and we're going to cover each of these in turn. Now, the skin and the subcutaneous fat provides a very important layer when looking at facelift surgery, as this really provides a cushion of evenness through which the facelift surgery can be seen. Patients with thin skin, well, these can be a little more challenging in one regard because even minor imperfections can be seen. Beneath the skin in subcutaneous tissue is the SMAS layer, and this layer is very important when it comes to facelift surgery, as this layer includes both soft tissues, muscle, fat, and it also provides a safe plane by which we can provide dissection and lifting, the facial nerves and other key structures lying deep to the SMAS layer. Now, with surgery, the SMAS layer can be clearly defined. It's a single anatomic unit and can be dissected out and be used to lift the face. Of course, there are lots of individual variations when it comes to SMAS. There's variable thickness in different areas of the face. It can be particularly thick over the parotid, and then it can be thin over the zygomatic arch. And with experience, you can learn how to lift these areas in their key anatomical areas. The other key aspect in facelift surgery is knowledge of the retaining ligaments, because these ligaments must be transected to enable lifting of the face. Because without freeing these ligaments, they will provide tight adhesions that limit the lifting of these areas. So, generally speaking, these ligaments are divided into osteocutaneous and fasciocutaneous ligaments. And the ones that are particularly pertinent to facelift surgery include the malar and zygomatic ligaments that must be released in order to lift the SMAS. And around the jawline, it's key to transect the mandibular ligament to allow freeing of the skin so that you can have smooth contour of the neck. And here we're looking at the mandibular ligaments, the zygomatic ligament, also known as McGregor's patch, and it's key that these ligaments are released in order to complete successful facelift surgery. Now, another key aspect of facelift surgery is the facial nerve, because key with this kind of surgery is that we avoid surgery in the vicinity of or branches of the facial nerve, as this can result in devastating complications. Now, the facial nerve, as we know, branches in the parotid and gives 5 main branches: the temporal, zygomatic, buccal, marginal, and cervical branches. And its knowledge of where these branches lie deep within the parotid and parotid capsule, well, with this understanding, it's key that with our dissection planes, we avoid going deep to these structures. Now, if there is a paralysis of one of these branches, well, we can see that each of these branches is not a single branch, but a multiple different branches. So even if there is a temporary paralysis, often the nerve function does return. The mandibular nerve is most frequently traumatized either through liposuction or surgery in the neck. And part of this is because the course of this nerve is highly variable. However, it lies deep to platysma and it lies proximal to the facial artery, and so keeping the key knowledge of this in terms of anatomical dissection will avoid trauma to this area. So we know that the facial nerve is important. Well, key is our ability to avoid or be cautious in specific areas of the face to avoid the facial nerve. And this particular book by Book and Seckel is extremely good at identifying these danger zones and how to avoid these specific areas. The other area of potential nerve injury is sensory nerves. And when we consider the sensory nerves, the great auricular nerve that lies 7.5 centimeters from the external auditory canal, well, this point known as Erb's point is best avoided when it comes to surgery. Now, this although anatomically this is regarded as 6.5 centimeters from the external auditory meatus, I generally mark an area of 6 to 8 centimeters, as it definitely has anatomical variation, and it's just key to be relatively superficial with dissection in this area. The parotid gland, well, this lies anterior to the ear and is important because the branches of the facial nerve are within it, but it can often be seen as a white glistening capsule that enables us to dissect in a safe plane superficial to the parotid gland. The platysma muscle, well, this is particularly important in the neck because in order to give a patient a well-defined and youthful neck, key is either anterior or posterior plication of this muscle in order to reduce platysmal bands and improve the contour of the neck and jawline. Other key structures are the submandibular glands that lie in this area, and in some patients there can be enlarged digastrics that can be reduced at the same time as surgery. And the final component is the bone, and there can be certain areas, the cheeks, the chin, which can be a little bit lacking in certain patients. In a patient with a smaller chin or flatter cheeks, they can benefit from augmentation either in the form of implants or fat transfer to give the best possible result. So let's have a look at concepts of facelift surgery. Well, we talked about the anatomical changes that occur with facial aging. Well, what we really want to achieve in a patient is a more youthful and natural appearance. And this requires improving the jawline, tightening the neck laxity, improving facial volume, and of course, removing the loose skin. Now, our knowledge of facelift surgery has changed over the years. The early facelifts were done in a way that was skin only, and this led to a very windswept appearance. And really from the 70s, our understanding of the SMAS and key importance of lifting the SMAS and giving a more natural look. And then really from the 1990s onwards, the concept of deep plane facelifting that might result in less anatomical dissection, faster recovery, these concepts became more widely accepted and used. So what is the ideal facelift? Well, it's an unoperated, natural appearance. The scars are discreet and relatively hidden. The patients have a relatively fast recovery and limited downtime, and are relatively free of complications. And then perhaps we also need to consider the expectations of the patient, because key is with rejuvenation is a natural result, which doesn't mean an absence of any lines or wrinkles or any folds in the skin. So in terms of the different SMAS techniques, well, there's plication of the SMAS, which involves lifting the SMAS and suturing it on itself. SMAS flap surgery, which involves formation of a SMAS flap that is then lifted and then the excess SMAS excised. And then a SMASectomy, where elliptical excision of the SMAS is completed in order to lift the SMAS in a specific vector. And then there's deep plane facelifting, which involves dissection beneath the SMAS layer in order to lift the face. And of key with facelift surgery is the neck, because in a patient who has facial aging, often the neck has changes in addition, and it's key to have a look at the neck at the same time and improve things like platysmal bands in order to give the patient the best result. And of course, other procedures can have high importance with these patients, because often facial aging is going to affect the patient's eyelids, volume loss, and other concepts such as non-surgical treatments may also provide important tools in order to help these patients long term. So now let's move on to clinical evaluation and surgical planning. So in terms of this element, well, these are the different elements that we're going to consider with this topic. Patient symptoms, patient history, assessment, examination, surgical versus non-surgical options, complementary procedures, and then anesthesia. So in terms of symptoms, well, facelift is often compromised by patients complaining of sagging skin, loss of their jawline, a fuller appearance, deeper lines like the nasolabial folds, bands in their neck, and increasing shadows. And in terms of this, well, younger patients often require smaller procedures such as a mini facelift, and patients after a certain age, well, often they're going to have both face and neck changes and really need a combined face and neck lift procedure to get the best result. Other key aspects of their history are going to be, well, do the patient smoke? Do they have cardiovascular issues such as raised blood pressure? Are they taking medicines that thin their blood, aspirin or herbal products? And do they have other important medical conditions such as diabetes? Smoking is certainly a critical aspect of patients' health that may affect their healing. It increased their chance of problematic skin necrosis and also slow healing and infections. The other element to this is patient expectations, and factors that may be worth looking for include patients complaining to staff members, life events such as breakups, professional issues, patients who've had multiple revisions in a short period of time. Certain professions can be more detail focused, and if there's any evidence that the patients had previously been unhappy with a relatively small procedure. These are all things that one must bear in mind in terms of expectations. Now, in terms of assessment, while looking at the jawline, we can see that this patient has skin laxity, they have loss of their jawline, they've got jowls where the cheek has dropped down, there's a square and fullness to the jawline, a more square jaw, deep nasolabial lines, marionette lines, facial wrinkles, bands in the neck, skin laxity. All of these changes are factors that should be looked at when assessing a patient for suitability for facelift. Then in terms of assessment of the face, well, we should also look at facial asymmetry, look at the characteristics of their face and point these out to patients on their photographs beforehand, look at the underlying bone structure. If they have a relatively small chin or flat cheeks, well, it may be helpful to provide greater volume or projection at the same time, and this could be in the terms of an implant, a chin or cheek implant. Have a look at the soft tissues. Has there been much volume loss, in which case the patients may benefit from procedures such as fat transfer? And look at the skin quality. Do they have many lines, wrinkles, enlarged pore size, in which case they may benefit from a skin treatment such as resurfacing and laser. And then it's also important to look for other things such as fullness in the neck relative to the salivary glands. Do they have pre-existent facial weakness or asymmetry? All of these things are important to point out before surgery. Also check for previous hidden scars behind the ears. And do they have a past history of treatments such as fillers or threads that may make this surgery more challenging? In terms of the neck, we'll have a look at platysmal bands. Is there any evidence of loose skin or fat? What is happening with their, in regards to the position of their chin? Do they have a relatively small chin? Look at the angle between their neck and their jawline, the cervical mental angle. How is it compromised? And then look at the skin. What is the tone? What is the relative laxity? Do you have many lines and pores, enlarged pores? Is there evidence of pigmentation and sun damage? How elastic is their skin? This may be important when judging skin excision. If they have very loose skin, well, it may be necessary to take that into account when removing it. In terms of non-surgical options, well, Botox can be helpful with early neck changes, fillers can be helpful with volume loss, and there are, of course, a growing number of non-surgical tightening methods, radiofrequency and ultrasound, that all may have a role in relatively mild patients. And, of course, skin treatments, peels, lasers, the use of platelet-rich plasma may all have a role in non-surgical patients. Complementary procedures, well, this lies a little bit outside the scope of this talk, but are very relevant for patients in terms of a chin implant, fat transfers, laser, eyelid surgery, brow lift, cheek implants. All of these may have a role for certain patients. The chin is particularly important in face and neck lift surgeries. This forms the bony structure in which any lifting is completed, and a useful guide is drawing a vertical line in a horizontal vertical line in a profile view from the upper lip and looking at the position of the chin in relation to this. And a chin that is quite recessed will benefit from a chin implant at the same time as face and neck lift surgery. Fuller glands in the neck can be more prominent in the postoperative period and should be managed in patients and intraoperatively, or at least discussed with the patient that they'll be present afterwards. This patient had lifelong fullness in her neck, and at the same time as face and neck lift surgery, I reshaped the inferior part of her submandibular salivary glands that enabled her to have an improved cervical angle. In terms of workup and investigations, well, we want to do our labs, we want pre-op clearance, we want to stop anticoagulants, other things that can be useful, showering with antibacterial soap, providing a prescription for patients and their post-operative needs. As a basic investigation should include full blood count, using ease, clotting, EKG in patients over 50 years of old, chest X-ray in patients over 60, and pregnancy tests are essential in any patient less than 50, and where relevant it may be helpful to provide both sickle cell testing and MRSA. In terms of patient information, well, medications, stopping anticoagulants, stopping herbal medicines that may thin the blood are of key importance with this kind of surgery. It's important to give patients written information in terms of recovery, their swelling, and then of course reminders can also be helpful, what to do at certain times before and after the surgery. Helpful tips, well, take particular care for patients who smoke. Really encourage patients to stop smoking. That will greatly reduce your chance of having issues with healing and necrosis. Controlling hypertension is very important, and reducing the use of anticoagulants in the perioperative period, a month before, month after. Cases such as very full and heavy necks, well, these are challenging and have a learning curve and often require deeper surgery to the submandibular salivary glands and are best avoided in early cases. In terms of patients, well, you can build up trust with patients, providing eyelid surgery, and a proportion of those patients will come back for face and neck lift surgery when they've had a really good result from the eyelid surgery. I provide my patients with detailed information on recovery and the healing period so that they are well informed in preparation. So now we're going to move on and talk a little bit about anaesthesia, and this has key importance in patient comfort in the surgery. Now, broadly speaking, there's three types of anaesthetic. There's general anaesthetic, which is commonly used in this kind of surgery, local anaesthetic with intravenous sedation, and local anaesthetic on its own. For me, local anaesthetic on its own, it's difficult to provide patients with this surgery as it's a little bit involved. I think you need to have at least oral sedation as a minimum. In terms of local anaesthetic, we'll talk through the different components of that. It definitely has a role in that sedation may result in less bruising and less swelling and faster healing, as things like blood pressure is maintained relatively in a normal place during this surgery with sedation. There's no major drops as there are in general anesthetic. Now, in terms of tumescent, well, this is one formulation that is particularly effective as a tumescent solution. It's important to infiltrate the areas of the face and neck thoroughly in order to reduce discomfort, because particularly providing this kind of surgery under sedation, if a patient is uncomfortable, the blood pressure will increase. That will make the surgery more challenging. But a patient who has excellent tumescent and local anesthetic will be very comfortable. Tips that I think are helpful are adding TXA to your tumescent and local anesthetic. This is an anti-fibrinolytic agent that will help in clotting the blood and reducing bleeding. Be cautious about adding too much tumescent, as this will result in excess stretching of the skin and potential laxity in the post-operative period. I personally always add extra tumescent at the end of the surgery, as this will provide comfort in the post-operative period. Be particularly careful with small 2x2 gauzes, as it's very easy to leave these gauzes behind, and I would advise you to use larger gauzes for these cases. So now let's move on to facelift techniques, primarily focusing on the SMAS. So in terms of facelift techniques, well, broadly speaking, the most modern facelift techniques either involve lifting of the SMAS or the deep plane lifting, which is beneath the SMAS. So in terms of our ideal facelift, what do we want to achieve? Well, we want an effective rejuvenation. We want relatively low risk. We want patients to have fast healing, low recovery times. We want it to last a long time, and we want relatively short surgery. Well, in terms of the anatomy we looked at earlier, well, in terms of the anatomy of the face, we have the SMAS layer that sits beneath the skin and the subcutaneous fascia. Now, in terms of the incision, well, when we plan the incision, as far as possible, we want it to lie in natural lines where it's hidden and discreet. And in front of the ear, well, we can complete a prostragal incision that lies along the border of the tragus that is relatively discreet and then can run into the hairline. The incision, depending on the laxity of skin in the neck, can then run behind the ear and into the occipital hair. Now, a skin flap is first formed, and this is key in order to get access to the SMAS layer, and it's important in order to free up the skin to enable the loose skin to be removed at the end of the surgery. Now, once the skin and subcutaneous fat is released, of key importance is release of specific ligaments that hold the soft tissues of the face in their position. This is key to enable effective lifting of the face and also to remove loose skin. So in the cheek area, we have the zygomatic and masseteric ligaments. Along the parotid, we have the parotid cutaneous ligaments. And then along the chin and jawline, we have the mandibular ligaments. Now, it is of importance with facelift surgery that all of these ligaments, at the very minimum, are released to enable a natural looking result. Now, in terms of the SMAS, well, this is a muscular, fatty, fibrous layer that lies beneath the skin and subcutaneous tissue. Now, it lies continuous superiorly as the galea in the scalp, and then it becomes the temporoparietal fascia, and then in the neck, the superficial cervical fascia. But it's clearly defined, and for us as surgeons, it provides us with a safe plane of dissection. Now, deep to the SMAS layer lies the parotid capsule and the parotid gland, and all the branches of the facial nerve lie deep to the SMAS layer. So as long as we remain in the correct anatomical plane, we remain in a safe area. Now, this figure shows us the area of dissection for a SMAS flap, and this is a common flap that is used by facelift surgeons. And we can use the zygomatic arch superiorly to demark the superior border of the flap. Inferiorly, we can run the flap incision along inferior to the jawline and the neck in order to improve the cervicomandibular angle. Here we can see an image of the flap being fashioned, and the flap here we can see it lies just beneath the zygomatic arch. Now, once the sufficient SMAS flap has been formed, On lifting this flap, we can see an immediate improvement in the jawline and neck. And as we can see in this picture, just pulling on one stitch can generate quite a high degree of lift. Now, it's a key of importance with fixation of the SMAS that it's fixed to something that is relatively fixed. The temporalis fascia provides an excellent area of anatomy that can be used to lift. Anterior to the tragus is a more hazardous area, as this could change the natural shape of the tragus. Now, once the SMAS has been lifted, there will be an excess of skin, and then of great importance in terms of the skin is reshaping the excess skin and avoiding unnatural changes such as elevation of the hairline, changes in the occipital hairline, changes or traction on the tragus that can really lead to a change in its shape. And the vectors for which the skin is lifted remain important. Pulling against the nasolabial fold will lift this area, and in terms of skin laxity, it's generally advised to lift in a more vertical direction in front of the ear to reduce the dog ear around the ear. Now, there are multiple different variations of the SMAS, as we mentioned earlier, and this includes SMASectomy, where a proportion of the SMAS is removed, plication, particularly in thinner patients where the SMAS is sutured upon itself. A high SMAS flap offers the benefit of lifting more of the cheek, which may lift the nasolabial fold, and the max lift, which involves a more modest procedure but with a faster operative time, really involving the use of sutures in order to lift against the temporalis fascia. The SMAS purse string suture, well, this is a common technique, particularly in surgeons starting out, as it's a relatively straightforward technique that will improve the face and neck area, and this involves placing a large suture to the temporalis fascia, lifting along vertically in the direction of the mandibular angle, and then anterior in the direction of the angle of the commissure. Now, deep plane facelift, well, this involves dissection deep to the SMAS layer and the malar fat pad, originally described by Hammer back in 1990, and involves drawing an incision into the SMAS layer between the orbital angle and the angle of the mandible. Now, this vector enables a oblique lift of the SMAS layer, but goes in the direction of lifting the nasolabial fold. It involves less dissection, there's less skin and subcutaneous dissection, and there is some evidence this may lead to a faster healing with less hemorrhage and swelling, and generally some of the incisions can be smaller as a result. The deep plane facelift does require excellent knowledge of the anatomy, as the facial nerve lies very deep to the layer of the SMAS, and care is required not to infringe this anatomical level, otherwise the facial nerve will be affected by the surgery. So in terms of concepts of facelifting, well, incision and planning are of key importance. Lifting of the skin and subcutaneous flap, which also require release of the facial ligaments. The SMAS is an effective and safe plane for both dissection and lift. Closure of the skin requires absolutely no tension to avoid stretching or larger scars. And then other skin elements such as consideration of the neck and volume changes. SMAS techniques are generally regarded as being safer, as they are a safer dissection plane. The deep plane is a more advanced technique and requires good understanding and knowledge of the facial anatomy, and there are many successful variations of the SMAS layer. As with many things, although there are many different techniques, it's about selecting the most appropriate treatment for each patient. There are other important considerations: the skin laxity and skin closure, neck and volume changes. So what are the key steps when it comes to learning this type of facelift surgery? Well, we've really summated these into 7 key steps, and this is what we used to cover in our anatomical and cadaver sessions. Marking the skin, application of tumescent, neck liposuction and platysmoplasty, incision to the skin, creation of the subcutaneous skin flap, SMAS flap and lifting, and finally skin closure. So let's just talk through some of these key components. So in terms of skin markings, well, we talked about the use of the post-tragus incision, hiding the scar along the tragus. At the top of the ear, there is a decision whether to go inferiorly under the temporal hair tuft. This avoids elevation of the temporal hair, or going into the temporal hair. Now, in patients with relatively modest laxity, going inferior to the temporal hair is fine. However, if patients have a great deal of skin laxity, going anterior in the hair can result in lifting of the hairline. Behind the ear, it's important that when the skin is closed, much care is taken with regards to the natural occipital hairline, as if this is changed, it creates a step-off deformity. The skin flap should be proportioned in degree of facial aging and degree of skin laxity. Now, in patients with more advanced aging, they will require more advanced dissection in order for that freeing of the loose skin that can be subsequently excised. Infiltration of tumescent is of key importance, and particularly in sedation anaesthesia techniques to enable a comfortable patient, and important in the post-operative period to avoid discomfort. In terms of the skin incision, well, it's particularly along areas where there is hair-growing skin, a beveled incision enables the scar to be angled such that once the hair regrows, it will regrow to include the scar, making the scar difficult to see. The neck is of key importance with face and neck consideration. Many patients have changes in their neck that require treatment at the same time. A skin incision of anywhere from 1 to 2 centimeters is usually adequate, but anywhere up to 4 centimeters can be used in patients requiring submandibular salivary gland reduction. The incisions should be 1 to 2 centimeters behind the submental crease, as this provides a good angle in the post-operative period. In terms of plication, well, the platysma can be plicated anteriorly, particularly if the platysmal bands are with a back cut, and posteriorly the platysma can be tightened to improve the cervicomental angle. The subcutaneous dissection is completed, and at this level it's important to also release the retaining ligaments. We discussed these earlier, including the zygomatic, malar, and mandibular ligaments. And this is where we must also bear relevance to the facial anatomy, with particular importance to the facial nerve and certain areas regarded as danger zones that we are cautious around. And then creation of the SMAS flap. And once the SMAS flap is created, it can then be lifted against the temporalis fascia to provide elevation and lift. We mentioned a number of different techniques that can be used to lift the SMAS in different ways, and then the skin is closed. So these remain the 7 key steps of facelift surgery, and in past years we've covered this comprehensively in both anatomy and cadaver dissections. So now we're going to go on to knowledge of complications, and this is of key importance in terms of facelift surgery. Well, we want to expect the best. We want patients to be free of complications, but it is important to plan for the worst case scenario and prepare to be surprised. So in terms of facelift complications, well, broadly speaking, we can divide those into intraoperative and perioperative complications. Those are short-term and long-term complications. So when we look at the early perioperative complications, well, these really center around hematoma, seroma, skin necrosis, and sometimes anesthetic issues. So in terms of bleeding, well, this can be intraoperatively, this can be in the form of hematoma, and rarely in the form of a rapidly expanding hematoma that must be dealt with as an emergency. Well, let's cover the expanding hematoma. This is far more common in general anesthetic, and this is related to like a blood vessel that's continued to ooze and can provide a massive distortion of the soft tissues of the face and the neck, and can be an emergency requiring the patient to go back to surgery, because eventually there will be sufficient bleeding that will actually has the potential to obstruct the airway. So this must be treated as an incident requiring immediate surgery to correct. Now, often during the surgery, it's found this kind of black currant appearance to the bleeding, and often it can be difficult to find the actual source of the bleeding, but all blood vessels are required cautery. Hematoma is relatively common after surgery, and there have been case reports in the literature and scientific reviews that have identified anywhere from 2 to 4% to even 15% of patients having this surgery being complicated with a hematoma. Now, the most frequent way this would be treated is with a drain, and this might require serial drainage in order to treat the collected blood. Bleeding intraoperatively, well, this may require good hemostasis, controlling of blood pressure. There are other special combat gauze that is treated with kaolin that can increase clotting in the time of surgery. And it's important to put these measures in place so that they're available at the time of the surgery when required. Seroma, well, this is fluid collection in the period after surgery. This can be treated with serial reduction with needles, each time draining of the fluid. However, there's a tendency for it to either need to be repeated every 2-3 days, or my preference is to use a special seroma cath, which can be inserted and left for a period of 5 days until there is no fluid draining from this area, in which case the seroma cath can then be removed. Necrosis can occur particularly in patients who smoke, who have reduced oxygen carriage to the peripheral areas of the flaps. However, it can happen also in patients without vascular compromise. And these patients, well, the skin can be sloughy, can be black in color, and have delayed healing. These patients can be managed conservatively with repeated dressings of their wounds, antibiotic cover to provide protection from infection. And if you have access to an oxygen chamber, well, that will provide better healing of the peripheral flaps. So now let's go on to short-term complications. Well, contour irregularities, nerve injuries, infections, parotid sialocele, suture exposures. Contour irregularities are relatively common in the early perioperative period, and these may be visible as lumpy, bumpy changes related to swelling, changes with the skin and scarring. They can be treated with massage, MLD or manual lymphatic drainage, injections with local steroids, and treatments with non-surgical treatments such as fillers. Nerve injury can be both sensory and motor. And in terms of the sensory nerves, well, the great auricular nerve can be injured even up to 7% of the time with face and neck lift surgery, and it lies at Erb's point beneath the external auditory meatus, where it can be damaged in the neck dissection. In this particular area, it is important to lie relatively superficial under the skin. The motor nerves can also be stretched in face and neck lift surgery, and this can happen even 2.5% of cases. In these patients, there will be visible facial asymmetry, particularly on smiling and in the postoperative period. The marginal mandibular nerve is the most common motor nerve that is affected, and can be treated with Botox in the good functioning side in order to rebalance while the nerve continues to heal. The buccal branch can also be affected, and this can give to an unusual smile with the lips pulling over to the good side. Most motor nerve paralysis does improve over a period of weeks and months, and with these changes, they're often slow to recover and can improve anywhere from 6 weeks to 6 months, but in most patients their full recovery does occur. Infection is relatively uncommon in face and neck lift surgery. There are, of course, risk factors such as diabetes. Infection can be acute in the perioperative period, in which case bacterial infection should be cultured and appropriate antibiotics given for your local area. Rare infections can also occur with Mycobacterium species, in which case infections can present even several weeks to months after the initial surgery. Sialocele, so this is where the parotid capsule has been violated and results in saliva leaking into the soft tissues, often results in acute asymmetrical swelling soon after surgery. With modern-day non-surgical Botox, this can be effectively treated by injecting Botox into the salivary gland, which temporarily reduces saliva production while natural healing occurs. And after 3 to 6 months, when the Botox wears off, often that initial damage to the capsule has repaired and the parotid gland works normally. Extruded sutures, so great care is required in thinner patients using sutures that have the potential to lie on the skin surface. Surgical techniques such as burying the knots will reduce the chance of these occurring. And finally, let's move on to long-term complications. Scarring, stigmata of pixie ears, stretched tragus, changes in the hairline, all of these are important. Hypertrophic scarring. Fortunately, most patients have good healing and good scars. However, particular caution is required in patients who have a history of bad scarring or certain ethnicities such as African and Afro-Caribbean ethnicities, which have greater risk of hypertrophic scarring. These patients may require the use of anti-inflammatory injections such as steroid into the hypertrophic scars over serial times in order to thin the scars down. And then facelift stigmata. Excessive removal of skin can lead to stretching such as pixie ear deformity, and this results in an unusual shape to the ear. Of key importance is looking at a patient's ear before surgery, as some patients have no earlobe present, and this makes them more risk of having a change such as this. Tragal blunting, where the actual shape of the tragus of the ear is stretched forwards, giving an unnatural appearance. This can be repaired and improved, however, it can be challenging if there is no skin laxity. Incisions can be well hidden along the tragus, but sometimes scars are made in front of this area, and these scars are often look very unnatural. These scars can be improved as long as it has been several years since the patient has had surgery, because then the scars can be removed with some of the skin laxity. And contour deformities in the neck, while excessive removal of the subplatysmal fat can result in cobra deformity, and this can be avoided with more conservative management of fat reduction in this neck area. And finally, it's worth mentioning procedure. Some patients may come to you asking for either just a facelift or just a neck lift, and often these patients require a combination of both. This patient really only wanted to have a neck lift, but it was important to dress their jowls at the time of the surgery, as this would have been highly prominent afterwards. And perhaps the most important with all of these is just being on hand and supporting your patients in order to overcome these complications. And there's no way of doing surgery without a risk of complications, but good rapport and good management of your patients will allow them to be supported during their recovery. So over the last hour, well, we've covered a great deal. We've covered facial aging, relevant facial anatomy, the key concepts of facelift surgery, how to clinically evaluate and plan the surgery, the types of anesthetic that can be used, what are the most common techniques in facelift surgery involving the SMAS and deep plane techniques, what are the 7 key steps that are required in facelift surgery, and knowledge of the complications and how to avoid them. I do hope that this has been useful for you, and if you have any further questions or any other thoughts, please feel free to contact me below. Many thanks for watching.